think it's more to do with like, even though they're taboo, they're very important. And if you consider them taboo, then you're less likely to get them checked, and then bad things can happen. So like cancer doesn't discriminate whether you think things are taboo or not.
Right. That's good to hear. This is what you will be working with. Okay, you're done. Yeah. So what we're just getting out is this is our male model, and she will be going over the prostate as well as the rectal exam. And then Sonia and I will be doing the breast exam. I'll be doing supine, which is laying down. If you have soup in your hand, yep, so supine.
Soup in your hand, and then you prone it on the ground.
Prone it on the ground. And then, can I ask you a quick question? Can I take it out of this?
Yes.
Or?
Yeah.
Looks like a.
Yeah, and there's a diagram in front so you know where any lumps or anything are.
Oh, that's good. I'm gonna take it further.
And some things that a lot of people forget is it's even important to do breast exams in males because, again, cancer doesn't discriminate your gender. So a lot of times men will be like, oh, no, I can't do that because I'm a man, I can't get breast cancer, but you most definitely can.
Here's our female model. And then the last one is, what is that?
These are different morphologies.
Do you want to use those?
It's just always a test.
Okay. So the first part is the breast exam. Do you want to go over this, Danny? I'll just do the supine part.
Sure.
Okay.
So one thing is important before you even touch the patient. It's important to make them feel comfortable, let them know everything that you're going to do before you do it. Because again, these areas are sensitive. But one thing's important is to first just look at the patient. And so you ask them to put their hands on their hips.
You guys can do it with us, actually. It's kind of fun, actually.
It's almost like you're on a roller coaster.
So sitting, so this is our seated rest.
Yeah, and then so when you're, and then you check for symmetrical, and then you check to see if there's any dimpling, anything popping out someplace where it shouldn't. You can kind of see this one, there's like an indent that you're gonna look for that. This one too. I mean, there's, you want to check the nipples and everything. And then so you put the hands up, and then you have them bend forward like this. And then you just want to make sure everything is symmetrical and looks the same.
And oftentimes the dimpling could mean that there is something growing that should not be there. Say if it's cancerous, the dimpling ends up, if you can imagine tissue being inside, it starts to kind of come together, come in almost like a scar would or a scab. You know, everyone's kind of had a scab and that tissue ends up coming together like this. So if you're noticing dimpling, that's what's going on within the breast tissue. There could be other things going on, but that's just a little tiny tidbit. So typically from the sitting position, we'll ask our patient to lay down. So the whole supine position, they'll be laying down as if you were in the doctor's office. And you're still looking for lumps, but you're also looking for lymphadenopathy. If your lymph nodes are getting backed up, that's leading to trouble also. And often the lymph nodes that we're looking for are right in the axillary space, so it's kind of like right here. So a lot of women, we're told to like look for lumps and things, but are we looking for the ones that are underneath our armpits? So
The breast kind of has a tail that comes up like this underneath of the armpit. And a lot of women who do, if you do self-exams, it's important to go up there as well because that's where you're going to find those lymph nodes.
So basically, actually I'm going to use this because when they lay down, they're typically covered. You know those hospital gowns that are kind of open in the back here, like, please just. So they're typically covered by this. So we'll just ask for one arm to be held out. And we'll uncover the breast, and then we ask them to lift their arm up like this over their head so that we can get to that the lymph nodes underneath their arm. And so we'll do one of these, you know, just kind of pressing underneath their arm. And then the next thing you're looking for are the lumps that might be in the breast that could lead to cancerous diagnoses. So what we're doing is kind of, I'm just going to start we're kind of going in a circle like this. I choose to do this way, but some people do typewriter, going across just like a typewriter would. Either way, you're going all the way across. So we go around I'm like this. And sometimes it is uncomfortable. You're like, okay, I'm touching someone else's skin and touching someone else's breast tissue, but it's important when you realize the impact it has on their life. If you do catch something, that's more important than being uncomfortable yourself. So you're going around, you go around, and then when you get to the middle, you're looking for a nipple discharge. Sometimes people will tell you that they have it, and some people can just, they didn't even know. So what you do is you would squeeze this way, and you would squeeze both ways. So, and she actually has nipples on this one. Then we're just looking for discharge, or if there's bleeding, or if there's cracking, because these are things you really want to, take care of before they walk out of your office. Anything else want to share?
In terms of like before we would do a physical exam, the first thing we do is we just ask them about their breasts essentially. So get a history and find out if they have any history of breast cancer in their family, if they have any pain or nipple discharge that they've noticed, if they do a monthly self-breast exam, so if they've noticed any lumps or bumps, and then starting at age 40, or at age 50, I'm sorry, so 50 to 74 is when you start doing the mammograms to look for.
Mammogram just meaning a picture of the inside of the breast, just to be clear on what it means.
Yeah.
So are you only looking for cancer, or are there other illnesses or disorders that can come from a breast exam?
So yeah, I mean, just anything abnormal. I mean, they could have swollen lymph nodes, and it may not even be cancer, but there's usually a reason lymph nodes are swollen. And then there also can be like, yeah, and then like a lot of women can get like rashes and stuff underneath their breasts, and it's always good to just see what's there.
And that kind of goes with the first part, just visual. Before you do anything, you always look and you listen if it's like your stomach or like your heart or something, and then you feel. So we look first, kind of listen, that's not part of this really, and then feel.
So would this be part of every physical exam for a woman and a man?
Yes, for a woman, no, for a man.
Well, depending on the complaint. I mean, if you're going to the emergency room because
Right,
you
yeah.
broke your ankle, then
We're
they're
not
not
gonna
going to
do
do
your
a
breast
breast
exam.
exam. But if you're going to see your primary care physician, like
The yearly
yeah, then
Okay.
it's very
checkup.
important.
Yearly.
Yeah.
Okay.
Typically happens.
So I've heard that if you have a family history of breast cancer, you're supposed to start the mammograms earlier.
Yes.
Yeah,
Like
that's true.
35 or 40.
Yeah, that's right.
And so that's like, and that just goes to the point of, you always have to talk to the patients, you always have to get a history before you do any kind of physical exam, because you don't necessarily know what you're looking for. So you brought up the question, well, what else can we find in the breast? Like there can be cysts, there can be fibroids, so that's still gonna feel like a mass, like that's not gonna feel any different than cancer. That's why you send the person, if you feel something, to get a mammogram, and if they see something, then you send them to get a biopsy, because you can't feel it and know what it is. And so say if you had a family history of breast cancer and then I felt a lump, like that's a lot more concerning to me when you're 35 years old than say, you have no family history of breast cancer. I felt a lump. Okay, it's probably nothing, but it's good to get it checked out. So that's like our history, and the questions that we ask are really what guide our physical exam. Does anyone want to try the self-breast exam?
Yeah, I mean,
It's cool.
there's lumps in here, so you can see,
Yeah,
you
you
test
can
yourself.
see
And the one reason that we wanted to do kind of these exams for you, because we know that they're taboo, but Disha had an experience where a female in the emergency room needed a pelvic exam, and she was uncomfortable with the male attendant doing it. Luckily, Disha has done it before, so she was able to do it. And like the nurses there hadn't done it, and they didn't know what to do, so it was really good to have some kind of knowledge of it so that you can kind of calm your patients down.
And for those who don't know what a pelvic exam is, it's also a very intimate process, because a woman is basically at the edge of the table and she's laying on her back and her legs are open to a speculum, which kind of is like a duckbill, but it's
Yeah.
put in to open up the vaginal area so you can see the cervix, which is a little bit further back. If you were looking at it down the tunnel, the cervix is at the end, but you want to see if there's any abnormalities or discoloration or discharge with that also leading to some type of pathology. You're looking for something may not be normal. Hopefully it is normal. So you're always like, I hope it's normal today. But So that's what a pelvic exam is. So she was probably more comfortable with Deisha doing it, who was competent in doing it, because you said some people didn't even know how to do it. But then also she's a female, and some people are more comfortable with that also. So that's what that is.
Yeah, I had an 18-year-old, she was 18 years old and had never had a pelvic exam and most likely had a yeast infection. And so I could see like her, when I looked at her cervix, it looked white and frothy. And so she just really didn't want the attending to do it. And so at that point, I mean, you can't treat what you don't see. And so they were kind of at a stalemate. And so I thought she was gonna cry. She was actually very cooperative. So a lot better than I would have been when I was 18, scared in the ER. So, does anyone want to try the breast exam before we move on to prostate?
Probably not gonna be an option, so we'll
I
have
was
to
gonna
have
say the
somebody.
model with 3, they come off and you can send them around even.
Okay. Yeah, I know Okay, so now, to not leave the males out, we're gonna talk a little bit about a prostate exam. And so it's the same thing, you're gonna ask questions about genital urinary history, so you'll ask them about their bowel habits, blood in their stool, if they have noticed any changes, and then around 40, that's when you can start doing the digital rectal exam, which you're gonna feel the prostate in doing that. And so this is again something that you would do only at your primary care physician, so you're not necessarily gonna do this if you go to the ER. Although I was in the ER in Fairfield 2 weeks ago and I had to do one on a female, and the attending said, I would rather you do it than me because your fingers are smaller, so it hurts less. And so the big thing that you would do is you always wear gloves because no one's gonna want you to stick your finger up their butt without gloves. And you always use a lot of lube because, again, it's a small space, and so if you can imagine, like it's not pleasant for the patient, and so if your finger slides in easier and slides out easier, it makes everyone happier. Yeah, sure. It's all brand. This is not like the greatest model to demonstrate it. So you would usually have the patient either lying lateral recumbents, you could do it like this, or what they would do is you would essentially like have them like on the edge of the table, and then they're gonna be like with their elbows on the table, and then you're behind them. And so what you do is, it's not really hard, but it's not very comfortable. So you essentially just go ahead and you, again, gloves and lube, all black. You stick your finger in and you feel like a little, well, that's never happened in real life. You stick your finger in and you kind of feel like a little ridge, and that's the prostate. And so you feel and you make sure that it feels normal, there's no masses, it's not hurting the person any more than like sticking a finger somewhere where they probably don't want it. And then you do a 360-degree sweep of your finger, and you pull it out, and usually you'll got some fecal matter on your finger, and then you can put it on like a hemocolt test to see if there's any blood in the rectum. And so the patient that I had a couple weeks ago in the ER actually had a GI bleed, and so when we did this test on her and we did the hemocolt, it actually came up positive. So you just like put it on the little film and they put a developer on it, and if it turns blue, that means that there is blood. And so then she had to get admitted, and they had to figure out where her GI bleeding was coming from. And so again, not the most pleasant exam, but it is useful. Yeah, it's very useful. It's something that I think every physician will use a lot in their clinical practice. And then if you do feel some kind of changes in the prostate, where it's not smooth or it's hard or you feel a mass, then at that point, you can go and say, okay, maybe we need to get this looked at and make sure the person doesn't have prostate cancer. The test that they were using before was prostate-specific antigen, so it's a blood test, but that's not really conclusive for prostate cancer. So the more studies they're doing, the more they're realizing that, yeah, like as you age, as males age, it just does increase. So sometimes, what happens is you'll have a lot of false positives. So you'll think that because their prostate-specific antigen is up, that the person has prostate cancer when they really don't. And so this is a hands-on way to kind of feel changes. So So again, not pleasant, but very important, and something that starting at age 40, every male should get once a year. And then same thing that we talked about with the female, it's really important to go over the history and then ask if they have a family history of prostate cancer. Because if I were to feel something and I had heard that, then that would kind of make me more nervous and more inclined to do more invasive testing.
So if someone had cancer at a younger age and it wasn't prostate cancer, do they start those screens then obviously earlier for them?
Yeah.
They had a personal history of cancer.
Yeah, then it would be. And again, like, I think every question Margaret's asking just always points back to, like, taking a good medical history, like they teach us this over and over, is what really helps you. It really guides you to figure out what's going on. Because when we'll make a differential list, so we'll do a history and we'll do a physical, and then we kind of figure out what's possibly going on. And the list could be huge, it could be 100 things, but the more specific questions you ask and the more information you have, the more you can rule stuff out. So if you had a history of any other kind of cancer, they would definitely be checking like testicular cancer, something, anything that can spread.
Here's the testicles if you wanna know.
Anyone wants that?
So, I mean, you would just go around, and it's important for males to do self-exams just as it is for females to do. And you just feel around, you can do it while you're in the shower, while you're cleaning yourself, get it done. But it's important to do, because if you feel something, like, even if it's not cancer, you could have like a testicular torsion, and that's an emergency. So it's just important to know kind of what you're feeling for, and know that it's not taboo, and it is important. So you test that out.
Any more questions?
Are you ready to start bringing people up to demonstrate? Or to return your demonstration on your mail?
So just like with Jen, with the otoscope, just have a couple volunteers and you can coach people through.
First volunteer.
You get a bonus point.